This presentation is going to discuss respiratory emergencies that we find in emergency medicine. Now, respiratory problems lead to respiratory distress. And respiratory distress is the body's attempt to compensate for a problem, either structural, disease process, whatever you may encounter. One of the most common EMS dispatches is respiratory stress, and there's all different reasons for why someone would be in respiratory distress. Some of the top 10 chronic conditions in the United States are respiratory in nature. Reactive airway disease like asthma, chronic diseases like COPD, and we see a lot of pneumonias in the United States, but this is a major health hazard for developing countries. And it can be from a myriad of things. It could be from poor maintenance programs, not getting antibiotics out appropriately and quick enough. So what we're discussing really is a lot of this has to do with external factors. Our respiratory system is well designed to be protective, and it's protected by our internal structures, but it actually can have some external issues affecting it, whether it be traumatic, environmental, or otherwise. Now, our drive to breathe is based upon the brain monitoring levels of CO2 in the blood and the pH of the cerebral spinal fluid. When the pH drops below a certain number and becomes a little more acidic, and CO2 levels, the torr pressure, rises to a certain level, it triggers a breathing response, a reflex. So breathing is not so much the action of getting oxygen in as much as it is exhaling CO2 out. So you can see when you end up having issues with ventilatory problems, it's due to the patient's drive to breathe, getting out that excess CO2. And we can build excess CO2 through normal processes like exertional activity. But we can have structural issues like we have with asthma, COPD, where we can't breathe out effectively, and that's going to cause issues with respiration. In addition, we can have structural abnormalities, an upper airway obstruction, foreign body. The most common form of obstruction in an unconscious patient, of course, is the tongue. Don't ever forget that. Traumatic injury. We can have lower airway obstruction through swelling or trauma, burns, chest wall impairment, and neuromuscular issues like chronic diseases like ALS, amyotrophic lateral sclerosis, but also these neuromuscular impairments can be caused by the brain being overwhelmed by a chemical. It can be like carbon monoxide, but also heroin. You know, heroin actually sedates the body and puts it into such a state that it no longer chooses to monitor CO2 levels in the blood and the CSF pH, which then leads to hypoventilation and agonal respirations, and finally, no breathing at all. So, if you take from this, understand that carbon dioxide is directly related to pH. The increased carbon dioxide increases carbonic acid and also increases hydrogen. And the more hydrogen you have, the lower your pH goes, more towards acidotic. So issues that can impair the ability for oxygen to cross over into the capillaries from the alveoli through that process of diffusion can be issues where the atelectasis, where we've actually got the alveoli collapsing. we can have the alveoli infected with fluid or having plasma crossing over, causing that obstruction, where now oxygen does not have a gathering point to make that diffusion across. Neurovascular issues resulting from trauma. A high cervical fracture, C2, C3, is going to get in the way of our phrenic nerve and the diaphragmatic impulse, so we won't be able to breathe. Flail chest changes the structure, and patients can't create that negative pressure arena by inhaling and causing lung expansion. And you can see there is a plethora, a large amount of different processes, diseases, trauma that can get in the way of ventilation. So remember, ventilation is the process of getting oxygen into the bloodstream. How does it do it? You breathe it in, oxygen fills the alveoli, 21% in room air. That 21% that's in that sac, the alveoli, is a higher percentage than what's in the capillary beds that are surrounding it. Based upon that and the laws of diffusion, oxygen will cross over, going from an area of high concentration to an area of low concentration. Inversely, CO2, since there are high levels in that blood that's just got pumped from the pulmonary artery, the right ventricle, is very rich in CO2. There's very, very little carbon dioxide that's in room air. Through that diffusion process, CO2 will carry across into the alveoli. That's known as gas exchange, but it's both gases working on the principle of diffusion. And take away from the fact that our drive to breathe is based upon high levels of CO2 and the pH of your cerebrospinal fluid. The only way CO2 is produced in the body is through the process of aerobic metabolism in the cells. Now, our problem with this inability to get proper ventilation and get oxygen into the capillaries is going to be a slippery slope down to respiratory and then cardiac arrest. So this is why we are aggressive as paramedics to assure a patent airway and get ventilation going again, whether we have to take it over or assist the patient as they are in their distress. Now, hyperventilation is when we breathe in excess of what we should be. We blow off excess CO2. Primarily, it's caused through an emotional response. It's when there's conscious involvement in the respiratory system. Your drive to breathe is really involuntary. It's based on the apneustic center at the base of the brain and the pons and the diencephalon working together to monitor CO2 levels and to trigger a breath. You're unaware of it from a conscious perspective. Hyperventilation is more of a conscious takeover of the respiratory center. So it overrides it, and as a result, we don't have a drive to breathe. We just start breathing excessively, and what ends up happening is we blow off excess CO2. We build up more oxygen than we need in our vasculature. Result of excessive oxygenation in the vasculature will lead to tingling in the fingers and toes and sometimes in the mouth, and the muscles will actually spasm. This can trigger more anxiety and more hyperventilation. Now, it used to be that we would give them that, quote, paper bag to rebreathe their CO2 and calm them down. But if you understand the science behind why we breathe, you'll understand that that's not an effective way to slow down someone's breathing. Just understand that the hyperventilation that they're doing is going to resolve itself on its own, primarily. The paper bag is pretty much an old wives' tale, and if anything can be potentially dangerous, because in addition to anxiety, there are other causes of hyperventilation that are much more serious, if not lethal, like a pulmonary embolus. So we make that leap to hyperventilation caused by anxiety, we have to rule out a lot of other factors. Right? And our treatment should always be the same. If they're breathing excessively, we increase the oxygen. If it's emotional, eventually it will stop on its own by simply being professional and trying to calm the patient down, usually getting a lot of family members out of the room and going into a one-on-one type of situation will calm them down. Have them drink a glass of water, that always seems to work as well, because that causes a stop in their voluntary breathing response. But really that paper bag technique is no longer in favor, not part of the curriculum. So let's just do a quick review of anatomy and physiology of the respiratory system. And we know that we have the structural portion of the respiratory system and then the functional. And just like a tree, the tree is structural, the trunk and the branches, going up to the functional area of the tree, which are the leaves. The leaves are responsible for photosynthesis and development of life on that end. We have an inverted tree where the structures lead down to the functional area of the alveoli. The upper airway consists, of course, of the naso and oropharynx. The recommended way to receive oxygen and room air is through the nose, because it's designed to warm, humidify, and cause turbulence, and also filter out. Breathing through the mouth, you don't have that same warmth and filtering. You can find that out on a cold day. If you breathe through your mouth, you will end up increasing your risk of hypothermia. You cover your mouth and breathe through your nose, and that warming factor of the nasopharynx will keep the room air warm as it goes into the lungs. This is known as turbination. The warmth trapping particles with the mucosa of the nose, as well as the hairs, cilia fibers in your nasal passages. The mouth and oropharynx, very vascular. A lot of mucous membranes. It's actually an entryway for sugars, for certain medications. So it's highly vascular, and it's really the entry point for food. Just realize that because it's very vascular, it has a high probability of swelling. The oro and nasopharynx both meet at the hypopharynx, and this is where the gag reflex center is located. As we leave the hypopharynx and we enter the larynx, now we are at the dividing line between the upper airway and the lower airway. So once again, the larynx, glottic opening, that is the boundary separating the upper from the lower airway. And of course, we know the thyroid cartilage. It's pronounced in men as Adam's apple. Women's not as pronounced, but it's the center of the trachea, and below that is the cricoid membrane, the cricothyroid cartilage. Cartilage and and connective tissue. That's what your trachea is made up of. The connective tissue is a flat piece of material, just like your esophagus, but it is held firmly into a circular shape by those cartilaginous rings, the tracheal rings. On either side of the glottis are holes known as piriform foci. They're actually pockets of tissue that sometimes deflect food away from the tracheal opening, assist the epiglottis with swallowing, and in traumatic intubations, there are times when you can actually push a tube in there thinking that it's going into the trach. You didn't have primary confirmation, and this can lead to one of the causes of traumatic intubation. Once again, the cricothyroid membrane is that space between the thyroid and cricoid cartilage, right below the Adam's apple, center in women, center of the trach in women. It's the opportunistic spot for insertion of surgical airways because it's non-vascular and it's very, very close to the skin. So a simple insertion of a needle for needle cricothyrotomy, or using a scalpel to slice open an area for a surgical airway, that's the spot that we use because of its location and its avascularization. Our concern as paramedics is maintaining an open airway. You can tell a good medic from a bad medic. A bad medic treats the left arm extremely well and focuses on that arm. All right? IV insertion, not caring about the patient's airway. A good medic will sometimes forego the IV in an effort to keep the airway open. We are masters of the airway. If EMTs are masters of trauma, we are masters of the airway. We can intubate people under a subway car. We are masters of this. So we have to always think about and understand the problems that can occur with the structures of the airway, leading the upper airway and the lower airway. If we can control that airway, then the patient has a much better chance for a good outcome. So the lower airway, moving down from the glottis, going down the trachea. The trachea bifurcates at the carina, and as you can see in this picture on the right, it goes from the right and left main stem. Now, if you notice, the right main stem is a little more pronounced, and it rides a little bit higher up. Remember, we've got 3 lobes on the right and 2 on the left to accommodate for the heart. If we push the tube a little bit too far past the carina, it's naturally going to slip into the right main stem bronchus. The structure of the trachea is to provide, its function is to provide an entry point for air to pass through down into the lower recesses of the lower airway, where the functional area is located, the alveoli. But in addition to creating that passageway, it also has protective qualities. Because the goal is just to get as purified air as possible. So through a network of cilia cells and goblet cells, these epithelial cells will trap particles. Once the inspired air gets into the alveoli, this is where that gas exchange is going to take place. So this is the functional area of the lungs. And you can see from this picture just the intricate nature of the capillary beds that surround the alveoli. And to put things into perspective, there are, in 1 drop of blood, approximately 50,000 red blood cells in one drop of blood. In 1 cubic millimeter, there are about 5 million red blood cells. These capillaries are so thin, so intricate, that only one red blood cell can pass at a time. So I want you to think about this as you're looking at that picture, just how microscopic this area is, and how intricate and delicate it is, and how the gas exchange takes place through diffusion properties in this microscopic area of the lungs. We have millions of these alveoli and capillary, surrounded by these capillaries, doing this. Every time we take a breath, the transference takes place. It works better in the microscopic sense. The surface area is a lot smaller and allows for better diffusion. Patients who suffer from chronic obstructive pulmonary disease will lose these little walls. And this, instead of being a network of 8 to 10 microscopic alveoli, will become one big alveoli. That gets in the way of diffusion, proper diffusion of oxygen, and more retention of CO2. So the main stem bronchi is going to branch into the lobar bronchi, the segmental, the subsegmental, and the bronchioles. The bronchioles are lined with smooth muscle, and they regulate the flow of air into the alveoli. In addition, they have goblet cells. Goblet cells produce mucus. And the mucus is there for that last cleansing, trapping of any particles to make sure that the air that's going into the alveoli is pure. We have the gel layer, the sol layer. Now the alveoli, of course, what we talk about, that's where the gas exchange takes place, through diffusion. There are two types of alveolar cells. You have type 1 that are almost empty, and then type 2 that can make new type 1. So they can reproduce. The capillary bed that surrounds the alveoli is fed from the pulmonary artery coming off the right ventricle to the pulmonary arterioles and down in. What happens with people with obstructive pulmonary diseases is that in addition to the alveoli getting larger, because the walls in between the little alveoli start to break away, turning into one big ball, well, that also changes the network of capillaries. The beds themselves are altered, and there are fewer of them. And what ends up happening is that there's a delay in getting that blood from the pulmonary arteriole into the capillary. As a result, there's a backflow of pressure. The backflow goes back to the pulmonary artery and causes an increase in diastolic or resting pressure against the right ventricle. So there's an increase in systemic vascular resistance coming off of the pulmonary arteriole because it's waiting to pump blood into those capillary beds that are damaged or not as intricate. As a result, we have an increase in blood pressure going against the right ventricle. This is known as pulmonary hypertension. This hypertension can actually cause blood thickening because there's very little distance to go from the heart to the lungs. There's swelling, And you see it going up the right atria to the great vessels. And when you can see it, patients with this disease, like cor pulmonale, thickening of the blood, they'll end up with JVD, they'll get clubbed fingers, and radial and pedal edema from this right-sided heart failure. You know, and that's the process, is the heart actually has two pumping locations. It handles two circulatory centers. There's the systemic circulatory system, which is pumping from the left ventricle up the aorta, down the thoracic aorta, the abdominal aorta, and out to the rest of the body. Renal arteries, your femoral arteries, upper structures, and of course the brain. That's your systemic circulation, and the left ventricle, of course, is responsible for that. But the right ventricle is responsible for pulmonary circulation. And that is a shorter journey going to one targeted organ, the lungs. And its purpose, just like systemic circulation, is gas exchange in the capillaries. Except systemic circulation, the gas exchange is oxygen getting dumped into the cells, and the cells dumping CO2 into the bloodstream. Whereas with pulmonary circulation, it's oxygen getting dumped into the circulatory system, and CO2 being crossed over into the alveoli. The process to breathe incorporates the laws of atmospheric pressure and the rules that nature abhors a vacuum. And what that means is that whatever level you're at, it's consistent throughout that level. There are no vacuumous spaces. Any area that is part of the atmosphere cannot be vacuumous. If you have a can, you suck out all of the air, okay, and it's closed. It's a vacuum. When you open it, you hear that pop, that rush. That's air going in because it's now exposed to the environment and air is going to rush in. Same is true when you breathe. The chest wall works with the chest muscles to expand the thorax, the thoracic cavity, and inside the thoracic cavity we have the lungs. What ends up happening is that the lungs are going to expand. They're able to freely expand because they are encased in that pleural sac. So they're not rubbing up against the chest wall. So it's a nice, easy, and painless expansion as the thorax begins to open up because the diaphragm has dropped and the chest walls have expanded. In the center of the chest wall is an area called the mediastinum. And the mediastinum has the heart, it has the aorta, the thoracic aorta. It can also have your phrenic nerve, and your vagal nerve goes right through here. So this is an area in the center of the chest, and it's protected by the sternum. These structures all are in place to allow us to take that breath, to cause the lungs to expand. Whatever air was in there is no longer the same pressure as the air in the atmosphere because of the increased size of the container. So the atmosphere has to fill that container. And that's how air rushes in when you take a breath. Inversely, when you exhale, the muscles relax, the chest wall contracts, the diaphragm moves up, and we literally take that excess air and we squeeze it out to maintain pressure with the atmosphere. So you can see as paramedics, our goal is to expose the airway to the atmosphere. If we do that, then everything else falls into place. And breathing will occur. This is why new community CPR with compression only is an acceptable type of compressions to get oxygen not only up to the brain but into the lungs. As long as the airway is open, when you do chest compressions, the downward thrust causes the lungs to contract, and that forces air out. A full release, allowing the chest to completely recoil, not only allows blood to return back to the heart, but also expands the lung fields, and air will rush in as long as the airway is open to the environment. That's the process of ventilation. Now, respiration is a cellular process. Respiration is the process of getting oxygen into the cell for the purpose of energy production. And the process known as aerobic metabolism that does this wastes CO2. So cells respire oxygen and expire CO2. So ventilation is movement in and out of the lungs. And we can have good ventilation but not good respiration. Our normal breathing is based on high levels of CO2. So we can measure that through capnography. We can see that our CO2 levels are the correct Torr pressure. You think about Henry's law, you think about Dalton's law when it talks about Torr pressure. How much gas can be in a container, compressed air in a container. The container is the cardiovascular system. There needs to be 80 to 100 torr of oxygen, and there needs to be 35 to 45 torr of CO2. It's a range because it can be flexible. Nitrogen takes up the vast majority of the container, but the exchanges, oxygen and CO2, make up the remaining portion. If there's too much CO2, it's going to compete with oxygen for container space. So the body says, let's get rid of the CO2, and that logically will allow more container space for oxygen to enter. And that, along with diffusion, allows for good saturation at the alveolar capillary level, and that's diffusion. Effective, of course, area of high concentration to an area of low concentration. Getting that blood down to the tissue is the challenge of the cardiovascular system. The red blood cells have, the hemoglobin in red blood cells have seeded 4 oxygen molecules. Okay, and that's great. They're now going to continue the journey back to the heart, to the left atrium. From there, it's the heart's responsibility to pump that red blood cell down to the tissue and the capillaries in the tissue to allow for the oxygen to carry across. Issues with this can cause disruption of perfusion. We talk about pulmonary embolus. We're not getting blood to the heart. We're not getting blood to the lungs. We have restricted blood flow, and what's happening is we get ventilation but no perfusion. This is known as a ventilation-perfusion mismatch, otherwise known as a VQ mismatch. So we know that the brain controls breathing, and we know that it's controlled by, the drive to breathe is based on CO2 levels and pH of cerebrospinal fluid. Okay. The ability to make a full and safe breath involves having stretch receptors that will prevent you from taking too deep a breath that you pop your lungs. This is known as the Herring-Brewer reflex. It's always good to have your patient breathing on their own. It's difficult to ventilate them because you bypass this fail-safe and the high potential for rupture of the lungs. Now, the cardiovascular system works alongside the respiratory system to get those newly oxygenated red blood cells down to the tissue so they can disperse their oxygen and have it used for aerobic metabolism. When the body senses that it's getting hypoxic, it's starting to hypoperfuse a little bit, the response will be sympathetic in nature. Increased heart rate, increased respiratory rate. But after a while, severe hypoxia can lead to bradycardia. You can have an inverse effect, takeover of the parasympathetic nervous system. As the brain stops being able to regulate activity because of the hypoxia, we end up going into a default setting, a parasympathetic tone, and that's where the bradycardia occurs. And as the heart gets more irritated through hypoxemia, it can lead to arrhythmias. We'll talk about that later. So this is the actual muscular control. Body is trying to increase the lung field to allow air to enter. And when it relaxes, it shuts down and forces air out. We need to have that pleural space being what we call potential space. It's like rubbing two pieces of paper together. The space in between those two pieces of paper is potential space. And that's what it looks like inside the chest wall. The lungs are not connected to the rib cage, they are protected by the pleural sac. Now, if the lungs rupture and air begins to gather inside the thoracic cavity, it can lead to changes in atmospheric pressures which can restrict breathing. Kidneys play a role in respiration as well. Kidneys deal with the metabolic acid-base balance. So they'll regulate levels of acidosis through sodium bicarbonate, the bicarbonate ion, and through increasing urination. They also look at fluid balances. They respond very sensitively to drops in pressure going into the nephrons. So they look for dehydration. When you're looking at your patient who is complaining of a respiratory distress situation, understand that if left untreated, most respiratory distresses will devolve into a cardiac arrest. So we need to do that respiratory assessment early. We're medics. This is our job. Is airway and breathing management aggressive when we have the tools and the technique to do it? Every assessment starts with a scene size up, of course. Okay, evaluate the scene for irritant gases, like carbon monoxide. Like the new thing we have now is helium. People are committing suicide using a helium tank. So that's an inert gas that competes with oxygen, and it can cause suffocation quickly. So you have to recognize that exists. Do not enter a scene that's unsafe. Form that general impression. That can be done at 6 feet. What are you looking at? Are they tripoding? Have they slumped over? Are they slumped back? What's the impression of the patient? Are they actively attempting to assist in their own care? That's distress. You'd really like to see the patient continue doing that until you can resolve the problem. You don't really want to take over breathing for them unless everything else fails. So this is the position of distress. When you're in a tripod position, it allows, of course, for use of accessory muscles in the back, scapula, okay, and also will change the pressure gradient inside the lungs. to try and allow for air to enter. Children, especially infants, don't have that sternocleidomastoid, those accessory muscles that allow for tripoding. So what they do is they are belly breathers. They use they'll force the diaphragm through work of abdominal muscles, and they also deal with sternal retractions. You remember the rib cage on an infant is soft. It's mostly osteoblast, not osteoclast. So it's not as rigid as an adult, and it's going to suck in an attempt to change the thoracic pressures. So when you're assessing your patient, you want to see what we talk about, the inspiratory-expiratory ratio and their tidal volumes. So when we want to know the tidal volumes, the normal tidal volume should be 5 to 7 kilos. 5 to 7 cc's per kilo. Okay, and you times that, the average is 500. Times that by the respiratory rate, and that'll get you your minute volume. Now you can see low tidal volumes. See if it's normal, it's, let's say, 12 times 500 is 6,000. So that's 6 liters is a good starting point for a normal minute volume. If their tidal volume is only about 200 now, and they're breathing at a rate of 20, we're going to have a drop in minute volume. So what will happen is the respiratory rate will increase to 30 and restore normal minute volume. But we got to find out why their tidal volume is so low. We also want to see that inspiratory-expiratory ratio. It should be a 1 to 2 ratio. 1 second inhalation, 2 second exhalation. That should be your normal IE ratio. Anything beyond that, and we're struggling to exhale. And you see that with reactive airway diseases like asthma. Really listen to lung sounds. You know, it's almost turning into a lost art. But it's a vital part of your assessment. Have the patient sit up, because a lot of the assessment is gravity-based. So you want to know you really want to do an assessment of all lung fields, as well as the trachea. So normal breath sounds, tracheal, you're going to hear loud inspiratory and expiratory. Bronchial, the inspiratory is going to be shorter, and the expiratory is going to be much longer, that 1 to 2 IE ratio. Bronchovesicular is the same, and vesicular is going to be longer inhalation and shorter exhalation. What are you listening for? Well, you want to hear something. There needs to be some type of air movement. A silent chest, of course, is ominous, as you know. So you want to hear like normal air movement, right? But if you hear issues like crackles, wheezes, right? This is a sign of either an obstruction or a problem with oxygenation. Issues like snoring, which would be possibly a partial obstruction of the upper airway. If you hear snoring when you listen to the trach. Gurgling, fluid in the airway. Stridor could be swelling. And sputum is what is coughed up from the alveoli. And we're interested in what you're coughing up as well as what color it is. And color has a lot to do with our overall diagnosis of the patient, because we can find out different disease processes or different types of obstruction based on the quality, nature, and color of sputum. So like frothy pink tinge sputum is rich in oxygen, it's plasma in nature, so we're talking about congestive heart failure. That's where there's a fluid shift because of increased hydrostatic pressure going back to the capillaries. Thick sputum is usually a sign of dehydration, whereas yellow-green or that purulent type of sputum is an infectious issue. Clear or white is a bronchitis, and blood-tinged, we're thinking possibly cancer or TB. So that's our normal breathing. And you see the respiratory centers in the apneustic center, the cerebellum, and the brainstem are all responsible for this. Now, if you look at the brain, the structure itself, it's encased in a skull. And it's very protective. It's got some cushioning, you know, the meninges and the subarachnoid, the arachnoid space where the CSF is located, as well as cerebrospinal fluid in the ventricles, in the center of the brain, allows for a nice cushioned area. But the one downside to this structure is that if there's ever swelling, it's got nowhere to go but down. So the brain will swell down. And this, unfortunately, is where all of our diagnostic centers are located, in the bottom portion of the brain. And if we're talking about respiratory, you know, there's two main areas, that brainstem, cerebellum, and if they're under pressure from a brain injury above it in the cerebrum, that pressure is going to change the way that you can breathe. So signs of brain injury will manifest itself with respiratory issues. And you can see the different types of breathing disorders that can occur with a neurologic injury. So we did our airway, we did our general impression, airway, breathing, and we move on to circulation. And we want to check skin color, you know, and look for nail beds. You know, in a warm environment, your nail bed should be pink. If it's colder, you might see a little cyanosis, but in a warm area, cyanotic nail beds are usually a bad sign, a sign of hypoperfusion. Healthy hemoglobin levels to reduce cyanosis, 12 to 14 grams per deciliter. And cyanosis will begin when you desaturate down to like 5 grams per deciliter. High levels of methemoglobin will have chocolate brown skin as a result. And this can be brought on by cyanide toxicity. So after we've done our primary assessment, we have anybody in respiratory distress, this is a priority transport. And I'm not talking about throw them on your shoulder and firemen carrying them down to the ambulance. I mean, you got to start thinking about how we're going to extract this patient, stair chair usage, are we going to take, you know, we're going to give medications here, we have to aggressively manage the airway. All these decisions are made right after your ABC assessment. Take a good history of present illness as well as past medical history. Investigate based on their chief complaint. Have they had an increased cough? Is it productive? Are they feverish? You know, these are all questions you want to ask them. Patients who have chronic conditions like asthma or COPD or frequent pneumonias will be able to tell you, because they've done it before, that their own medical control. So you ask them their history, like, what's happened in the past? Is this one of the worst attacks you've ever had if it's asthma? Yes. What happened the last time you had an attack like this? I was in the ICU on a ventilator for 2 weeks. That's a serious patient in my mind. Take your sample history, get the medications, the allergies, last oral intake. Last oral intake is very important because you may have to take over airway for this patient and manipulate, do actually a laryngoscopy, and if they just ate, there's a high probability of vomiting, so you want to have suction ready. Look at the level of consciousness when you're talking to your patient. You know, decline in partial pressure of oxygen, the patient will start to manifest with neurologic complaints, restlessness. The brain is irritated, needs oxygen. So the patient is going to initially have that change in mental status. It's pretty quick. Check for signs of pulmonary hypertension. You see that with JVD. Okay? And it can be at 45 or even 90 degrees. Check for signs of tension pneumothorax. When we're talking no tracheal deviation, you got to remember that the trachea is encompassed by muscles around the neck. And you're not going to see a real shifting on physical. You got to feel down by the manubrium to feel for those tracheal rings. If you can't feel those tracheal rings, you've got a shift. But that's where the shift is going to occur. You're not going to see a guy's Adam's apple lining up with his left ear. That's not appropriate. You're never going to see that. You got to feel for tracheal shift. We can do things like the hepatojugular reflex, where you put a patient in a semi-phalanx position and you palpate the liver. Patients in true respiratory distress will have that hepatojugular reflex. That's that clinical sign of pulmonary hypertension. Other signs of this right side heart failure, you're going to see that clubbing of the fingers, cerebral edema, clubbing of the fingers and distal edema, pedal and radial. Look for pulsus paradoxus. This is really done when it's hard to do manually, checking for a blood pressure and seeing that decrease in systolic every time a patient takes a breath. These are things that are looked at when the patient is having hemodynamic monitoring. When you can test the blood pressure constantly, you're watching a patient breathe, and as you're looking at the systolic pressure constantly dipping. That's pulsus paradoxus. Pulse oximetry, still part of your toolbox. Remember, you want to have at least 95. 95 to 100 is normal range. And look at the nail beds. If it's cold and the nail beds are blue, you're not going to get a good saturation rating. Right? If it's warm, check it out. But also remember that if you've got patients who are in certain types of hypoperfusion, shock, you're not going to get a good oxygen saturation. Also, carbon monoxide poisoning will give you a distortedly high O2 sat. And the O2 should match the patient's palpated heart rate. It's another sign that you possibly are not getting a right reading. If it doesn't, if the heart rate on the pulse ox is not matching their pulse, that's a sign that it's not effective. So, pulse oximetry is monitoring the oxy-hemoglobin dissociation curve. And what that is it's a relationship to hemoglobin. Hemoglobin has a tendency to be attracted or have an affinity for more of something. Just like diffusion, you go from an area of high concentration or an area of low concentration. Well, hemoglobin loses its affinity for a gas when it sees less of it in the surrounding area. Inversely, when it sees more of it, it becomes more attracted. Let's take a look at this under the physiologic workings of the cardiovascular system. So, at the lungs, in a normal environment, 21% oxygen, what you're going to have is oxygen crossing across the alveoli into the capillaries through that process of diffusion, going from an area of high concentration to an area of low concentration, and hoping to balance it out. So we're moving across into the capillaries. And of course, inversely, CO2 is moving away. So there's less CO2 and there's more oxygen. The hemoglobin becomes attracted to oxygen because it sees more of it at this point. So the hemoglobin on the red blood cells that are going by seat the 4 oxygen molecules and continue the journey. They have affinity for this oxygen. The affinity starts to wear off when the oxygen levels, the percentage of oxygen levels in the bloodstream begin to wear off. And inversely, the CO2 levels begin to increase. Where do you see that? Well, you see it down in the capillaries that intertwine around the tissue. So as the hemoglobin enters into this capillary bed through the red blood cells, the hemoglobin sees that there's fewer oxygen, and it loses its affinity for the 4 oxygen molecules that it's carrying. It unseats it, and it couldn't come at a better time because the oxygen is now able to go across into the tissue and enter the cells and be part of aerobic metabolism and ATP production. So that's the carboxyhemoglobin dissociation curve. The more oxygen you have, the more affinity hemoglobin has. The less oxygen you have, the less affinity hemoglobin has. So take a look at this. So you look from down here, this is the the pressures of oxygen, partial pressure of oxygen in the arteries. So when it's low, at its lowest point, the oxygen saturation is very low. Hemoglobin is not attracted, does not have an affinity for oxygen. But as you increase the amount of oxygen, you can see that hemoglobin begins to saturate with oxygen. The more there is, the more there's saturation, until you're at the normal ranges of 80 to 100 partial pressure. That's where you have your maximum oxygen saturation. So what you're looking at, when you have levels between 95 and 100, you should have torque pressures of at least 90, which is in that range of 80 to 100. If you start losing torque pressure of oxygen, the remaining oxygen is going to be ignored by the hemoglobin. And that's the carboxyhemoglobin dissociation curve. This is why oxygenation is so important. Even at 2 liters by nasal cannula can increase your percentage of oxygen in inspired air from 21% to 30 or 44%. And that 44% is going to diffuse across faster. There's higher concentration going in. It's going to diffuse across faster. It's going to increase the partial pressure of oxygen in the blood and cause the hemoglobin to have a higher affinity to capture it and transport it down. That's why oxygenation has no contraindication. So, pulse oximetry can measure torque pressure of oxygen in arterial blood. End-tidal CO2 is the way to measure torque pressure of carbon dioxide. So you need to have 80 to 100 torr of oxygen in the container to have full effective oxygenation with hemoglobin involvement. And you need to have 35 to 45 torr pressure in the blood to be at the range where you can maintain your respiratory rate. We can tell end-tidal CO2 through end-tidal CO2 monitoring, capnography, that we are producing CO2. Since we're only getting about, let's say, maybe in room air, maybe we get a little bit crossing over. The only way that we have CO2 in the blood is as a waste product of cellular aerobic metabolism. Adolf Fick, German scientist in the 19th century, came up with his Fick principle. And it's a mathematical equation that I'm not going to get into, but what he said, his hypothesis, is very simple and is the basis of capnography. Adolf Fick plainly said, to know that there is metabolism is to see waste. To know that there's metabolism is to see waste. If you drive past a factory and there's smoke coming out of the smokestacks, you know that the factory is working. There's production because you see waste. And end-tidal carbon dioxide monitoring shows us the presence or absence of aerobic metabolism. Now, a quick way to tell that you're in the lungs, type of secondary confirmation, of course, is having that end-tidal capnographer or that little litmus paper test to see that you have CO2 in the tube. I mean, that will tell you that you're in the lungs. If you have CO2 in the tube that stays there for more than 30 seconds. That's an important caveat to remember about this litmus paper or any type of end-tidal monitoring, is that you got to look for it for 30 seconds because if, in a cardiac arrest setting, if you're prepping your patient for intubation, you're hyperventilating the patient, there is a possibility, a very strong possibility, you're going to force CO2 into the stomach. So having an initial kick CO2 response could still mean that you're in the stomach. But after 30 seconds, all that excess CO2 that you pumped in there is going to be gone. So watch for that when you're using this litmus paper as part of your secondary confirmation process. What we're looking at in waveform capnography is vital for our work as paramedics. A capnogram is going to show you that expiratory phase. Now remember, inspiratory is 1 second, expiratory is 2, right? That's your IE ratio. So if you're looking at normal IE ratios, you can see that when it's flat at 0, the patient is inhaling, they're inspiring. When it shoots up, that's your expiratory phase. Now you can look and see as it goes up, it's pretty pronounced, going from 0 to, let's say, 30, 31, right there. And then it gradually gets higher. It slopes gently up to the end where that black dot's located. That's the end of the expiratory phase. Why does it have that gentle slope? When you breathe in, when air enters the lungs through changes in atmospheric pressure, you get air going down the trachea, down the bronchus, and into the alveoli. So the functional area is the alveoli. The other areas are structural, but they're filled with air. This is known as dead air space. So when you start exhaling, the first air to come out is that dead air, and it's lower in carbon dioxide for the simple fact that there was no gas exchange taking place. It's higher in oxygen and less carbon dioxide. We got to wait for the end of the line, the end of the expiratory phase, to know that that's the alveolar pressures. That's why we do end-tidal CO2. It's the end of the expiratory phase, the end of that tidal phase. That will give you the most accurate number. So if you're watching this and you see that's a normal capnogram. Patients with bronchospasm, they can't get the air out. So you know what ends up happening? You look at the shark fin appearance. It is extremely flat. There's no excess CO2. What you're just looking at is that dead air space. That's it. You need to have that gradual climb to show that there's good air movement. "35 to 45 torr is normal pressure gradient for patients who are awake, alert, and undergoing good aerobic metabolism. Cardiac arrest, of course, the cells are not getting oxygen delivered. They're still alive, but they're working off an anaerobic metabolism. What's happened primarily in cardiac arrest is the heart stopped beating, the pumps stopped working, but the cells are still alive. They just looked outside the window and they saw that traffic has stopped, okay? So that's what happens in cardiac arrest. As a result, they start going through anaerobic metabolism, and they, instead of producing CO2 as a waste product, they produce lactic acid, right? They burn sugar without oxygen, and the lactic acid that's produced makes them metabolically acidotic. So we want to prevent that from happening. Cardiac arrest, we want to get torque pressures between 10 and 20. Because we understand that when we're doing chest compressions, we're not perfusing all the cells, just the brain, heart, and lungs. So we should get some type of return of CO2 production, CO2 waste through aerobic metabolism. Dropping below 10, less than optimal chest compressions. Now, using end-tidal CO2s, if you suddenly see a jump in the waveform, it suddenly spikes up and goes, let's say, to 25, 28, and you were originally at 15, check for a pulse. You may have encountered a spontaneous return of compression, of circulation. We also do peak tests, the peak expiratory flow meters, where we want to see how much air can be exhaled. Once again, the process, the drive to breathe based on CO2 levels, how much air can we get out, meaning how much CO2 can we excrete. Normal values, 350 to 700 in some cases, and it varies by not only just the age, sex, and height, but also by activity, their physical fitness. An inadequate level is anything 150 or below. So our treatment is going to be oxygen, oxygen, oxygen. Work on that carboxyhemoglobin dissociation curve. Keep it to the right shift. Get the hemoglobin more attracted to the oxygen by increasing the amount of oxygen that's diffusing across. Want to keep saturations at 93 or better. That will assure good delivery of the oxygen. Put in an IV. Provide psychological support. The IV is important because you may have to take over ventilations for this patient while they're still conscious and struggling, so you may have to induce them prior to airway control, and that's only done through IV drugs. And the medications that we give for respiratory distress activate or mimic autonomic nervous system control. Remember that the autonomic nervous system, the involuntary nervous system, is divided into two groups. You have the sympathetic and the parasympathetic. The fight or flight, feed or breathe. Our default setting is parasympathetic. Laying on the couch, eating potato chips, watching TV. Digesting, relaxing, processing, and in a relaxed state, that's great. That's monitored by the parasympathetic nervous system, and it's regulated by the chemical messenger acetylcholine that's used to put the targeted organs into that state. The fight or flight is a more temporary measure to deal with a problem. It's a stress response. And our bodies are 10,000-year-old models, so you think, all right, so 10,000 years ago, we're living in caves, you're going to fight an animal that came in to attack you or run away from it. And the same thing is true. We deal with stress by sympathetic response. Increase heart rate, increase blood pressure, respirations increase by bronchial dilation, our pupils dilate, we're able to make decisions quicker. We get more oxygen, it's pumped faster to the brain. Higher acuity of knowledge and ability to move faster. Muscles get more oxygen and we can move. So when we treat patients, we affect one system or the other. like giving an aerosol therapy, you give albuterol sulfate, what is it? It's a beta agonist. So it affects beta receptors on the heart and lungs. Beta activation is used by sympathetic stimulation. The neurotransmitter of the sympathetic nervous system is epinephrine and norepi. When they attack beta receptors, they tell the heart to pump harder and faster and the lungs to dilate. So we're basically giving a sympathomimetic. It mimics sympathetic tone, this albuterol. Also, we mix albuterol with Atrovent to make a complement treatment. And Atrovent blocks parasympathetic tone. So we're mimicking sympathetic tone and we're blocking parasympathetic tone. Why are we doing that? Well, in the feeder breed, this is when we create mucus. And you want to have a drier environment. You want to dry up those secretions that happen with the reactive airway disease. The goblet cells are being overstimulated and they are kicking out excess mucus. We want to dry that up, block that vagal response, and instead have a nice open air passage that can maximize oxygenation and, more importantly, get rid of that excess CO2 that's been trapped. We always stay in contact with medical control, always make assumptions that our treatments are not going to be effective. That's why we have different levels. If your initial CombiVent treatments aren't effective, we are going to have to go with a stronger beta agonist like epinephrine or terbutaline, or that's what you have a conversation with medical control about. Our goal is basically to provide this supportive care, assist the patient in their distress, and try and resolve it with medications. Okay, make sure that airway is adequate, of course. Decrease the work and effort of breathing, done medicinally. Start off with oxygen, and then move to other medications that are sympathomimetic in nature. In addition, you want to help the patient sit up, put them in a position of comfort, remove any restrictive clothing, of course. You want to try and relieve any gastric distension. You can think about insertion of a nasal gastric tube to relieve that, especially in children. And think about oxygenation. And listen, nasal cannula, nebulizer is fine. If they're in distress, they're breathing at a rate of 24 breaths a minute or more, that's a clinical sign that they are having initial stages of hypoxia. You can't make the assumption that they're hyperventilating right there during your initial assessment, during your primary assessment. So you want to give them oxygen and then find out the cause and effect of what's going on. You can always take the oxygen off or decrease it in percentage. But there's nothing wrong with giving more oxygen. It's going to be helpful to the physiology of the cardiovascular system. So that bronchodilator, those beta-2 specific medications like albuterol, levobuterol that's out there, very common treatment, not only home-based but also EMS. And you know, why does ours seem to work better? Because it's always attached to oxygen. And we're doing a two-step process. We're causing bronchodilation, releasing that CO2, but we're also now giving more concentration of oxygen into the alveoli, better, more effective diffusion, higher oxygen levels, partial pressures of oxygen, better affinity for the hemoglobin. Other drugs we have more, we're talking about smooth muscle relaxers, methylxanthines. They have a very narrow therapeutic threshold. They can become toxic really fast. Patients have been known to seize. We used to give these by IV, if you remember. Aminophylline used to be given a lot. Methylxanthines have kind of fallen out of favor, and now we've thought more about magnesium sulfate as a better drug. I mean, these electrolytes, mag sulfate is a great electrolyte that's found to be an effective muscle relaxer, and it doesn't have that narrow therapeutic threshold. Corticosteroids are there after the fact. So once you have stopped the inflammation, the corticosteroids are there to prevent the inflammation from reoccurring. Remember, there's adverse effects. You can see an increase in blood glucose levels, either up or sometimes down. And it does blunt the immune system. So a lot of times, if the asthma is being caused by pneumonia, if they've got a productive cough with yellow sputum, you might want to, once you've corrected the wheezing, you might want to restrict the use of corticosteroids because you're going to get in the way of the body's response to the infection. These inhaled corticosteroids are becoming the industry standard because they're less long-acting and they don't involve a lot of different systems like intravenous corticosteroids. You've got to always think about the entire history. So before you even give medications, you need to talk to the patient and get a good story. Now, if this is not a reactive airway disease, but instead a fluid overload, there's excess fluid, increasing of hydrostatic pressures in the tissue, the capillary beds that are around the tissue, you're going to have movement of fluid, a shifting of fluid to relieve that hydrostatic pressure. It's going to shift across into the tissue and we're going to have peripheral edema. And in the pulmonary side, the capillary beds are going to, that's where the hydrostatic pressure relief is going to occur, and it's going to shift into the lungs, and we're going to end up with pulmonary edema. So we got to find out if we're going to give a vasodilator to reduce preload and deal with the hydrostatic pressure, reduction of hydrostatic pressure, and therefore relief of that pulmonary edema. In addition, if that's not working, we think about issues like Lasix. Loop diuretic can be helpful in some instances, but it can also be harmful because you got to ask yourself, is the patient in pulmonary edema because of excess fluid, or are they in pump failure? If they're in pump failure, we need to relieve the pump and not so much get rid of all that sodium that is required for pumps to work appropriately. So the school of thought now has shifted from diuresis to vasodilation and positive pressure ventilation like CPAP. We always want to make sure we restore fluid balance. A lot of asthmatics become dehydrated. It's one of the causes of their reactive airway disease exacerbation. So fluid challenges on younger people are very much more effective than on older people. Older people don't have that response to fluid and cause an increase in hydrostatic pressure and pulmonary edema. So be very careful and listen for breath sounds before and after. So if you are going to administer a diabetic, know that you are reducing blood pressure by taking fluid out of the circulation. And the fluid that's going out of the circulation, the reason it's getting out is because it's preventing the body from reabsorbing sodium at the ascending loop Henle or descending tubules. So depending on what area is being affected will tell you how much sodium is being lost. A loop diuretic like Lasix is a drug that you lose the most sodium, and too much sodium loss can lead to hyponatremia and cardiovascular compromise. So this is why diuretics, think about why you're giving it. In addition to that sodium loss, it loses potassium. So you need sodium, you need potassium for that good cardiovascular response. A lot of patients, well, not a lot, almost every patient that's on an oral diuretic takes a potassium supplement, like K-Dur. So we're thinking more about reducing preload, possibly reducing afterload, preload with the nitro, afterload with the morphine, and positive pressure ventilation. Using these new, well, they're not really new, they're new to EMS, CPAP and BiPAP. Continuous positive airway pressure is used for sleep apnea. Patients who snore excessively or have periods where they stop breathing at night, they need that positive pressure during the end expiratory phase. In addition, it will save people who are starting to go into respiratory failure from going into full-blown respiratory failure where they need to be intubated. How does CPAP work? Okay, air is actually forced in, and it's patient-driven, so the patient has to be breathing in order for this to be effective. As the patient breathes in, it forces air and increases the lung capacity and allows for more air to enter and be utilized. Now that's going to create more pressure in the alveolar space, which is going to compete with the hydrostatic pressure and hopefully force the fluid back into the vasculature. So with the positive pressure going in and the vasodilatory effects decreasing preload, reducing the amount of blood going in, that double team approach will reduce hydrostatic pressure and relieve pulmonary edema. CPAP is patient driven, so we still have that Herron-Brewer reflex, but if it's too high up, it can cause tension pneumothorax, you can get subcutaneous emphysema, there's issues. So we think about this, emphasize with your CPAP use, don't be overly aggressive and cause more structural damage in an effort to combat the respiratory distress. Think about lower ventilatory rates, smaller volumes, lower pressures, especially when you have to take over ventilations and you have to intubate your patient or put them on a vent. With CPAP, it's used, you ensure a tight seal, and that's why we have that mask, that netting that goes around the back. If they're freaking out and they can't use it, don't fight them. I mean, you can say simple things like, it's as good, just focus on breathing and close your eyes. Lots of times they might feel like they're suffocating because they're visualizing the mask. So just the thought of having them close their eyes. There are other tricks you can do. You just kind of talk to them calmly. But if they're freaking out and they can't handle it, then we have to take it off. And then let medical control know that this happened. Now we go to the hospital, and now we deal with in-hospital stuff. We have a BiPAP machine. This is pressure on inspiration and a different pressure on exhalation. So it's very complex. It's hospital purchased, and right now it's very expensive. Might we see this in the next 5 years on ambulances? Sure, but right now we deal with continuous pressure and not this bi-pressure on inspiration and expiration. As paramedics, we come in contact with ventilators. We need to understand the purpose of ventilators. It's an automatic system that's going to give consistent tidal volumes, that's going to be best for physiology. BVM alters. It's a manual process. It's not completely accurate. It's not going to give you the same respiratory rate. Your minute volume is going to be different because your tidal volumes are going to change depending on the person who's squeezing the bag or how tired they're getting. But a vent, you can keep them on a vent for a long time. You need to have knowledge of the particular vent that you're going to be using when you're doing a transport. So for this program, for the curriculum, what you need to understand about vents, very, very important. There are two things you need to understand. Two basic qualities of a vent. A vent is going to give a ventilatory rate and a tidal volume setting. So like I said before, tidal volumes can range between 5 and 7 cc's per kilo. So if you have a 100 kilo patient and they're going at 5 cc's per kilo, that's a tidal volume of 500 cc's. Now if you have a 60 kilo patient who's only 130 pounds, let's say, 500 cc's is going to possibly cause pulmonary damage. So we use that weight base and we go, all right, instead of 500, we're going to go at 300. So understanding tidal volumes as far as vent settings go, very important. So tidal volumes and respiratory rate gives you your minute volume. So maybe a 300 cc tidal volume, you might want to increase the respiratory rate to about 15 to 20. Whereas if you're infusing 500 cc's, when you're working on that 6 liter minute volume model, you might want to lower your respiratory rate down to 10 or 12. The other thing you can do, if you're doing a transfer, critical care move, is mimic the vent settings that were set up by respiratory. Why? Because they have more knowledge of the blood gas chemistry, and they've made a diagnosis, so you can mimic their vent settings. intubation is the final step. If you're choosing to intubate your patient, they are in respiratory failure, they're unable to assist in their own care, and they are near death. It's very difficult to do for patients who are like asthmatics, COPDers, pulmonary edemas, who are still conscious, maybe not alert, but conscious and struggling to breathe. Of course, as we know, with diabetics and suspected opiate overdoses, giving them D50 or Narcan will no longer necessitate the need for intubation. That's why we do our full assessment. So once again, the tongue, most common cause of airway obstruction in an unconscious or semi-conscious patient. Why do I keep saying that? Oh, I don't know, because it's probably something that you will definitely see on every exam that you take. And it's a very common thing that we need to address when we're ventilating our patient. The way that we correct those anatomical obstruction, that very common anatomical obstruction, is use of an airway. Use an airway. If you're going to ventilate the patient, use the airway, because otherwise you're forcing the tongue in the back of the throat, the epiglottis is closing over the glottic opening, and we are now pumping air into the stomach. When you're doing your assessment for level of consciousness, look for audible signs. Sonorous respirations, gurgling, that's a sign that the tongue has relaxed into the back of the throat, into the hypopharynx. Putting someone in a recovery position on their side usually corrects that issue. Other issues with airway obstruction be caused by inflammation. And you just manifest itself, you hear stridor, hoarseness, cough, is an inflammation which can lead to airway obstruction, partial in nature, sure, but also these patients, they need to have, it's going to restrict the flow going down to the alveoli. And of course, it's going to get in the way of diffusion, and it can also cause issues with that dissociation curve. Pusoil's law says that as the diameter of a tube decreases, resistance to flow increases. And inversely, as the diaphragm expands, flow increases, but pressure drops. So as you get narrower, the pressure goes up, but flow goes down. As you get wider, flow goes up, but pressure goes down. Another type of inflammation we have, croup, see that with children, tonsillitis. With that, there are issues with the airway being inflamed, and if you manipulate the airway in any way, insert your laryngoscope, it can cause a sudden increase in inflammation that can lead to complete airway closure. Patients who are at risk of aspiration, usually these are unconscious patients on feeding tubes, laying flat, so also unresponsive patients, patients who are in cardiac arrest who have vomited. That's why we want to get on the airway right away. If you aspirate your stomach contents, very high mortality. Very common cause of pneumonia in older patients is aspiration of food, especially if they're fed by a gastric tube. So if you see gastric distension when you are ventilating your patient, you arrive on the scene and the first responders there have inflated the stomach to such a way that it's going to restrict returning venous blood flow. So you want to relieve that distension. And you can use a nasogastric tube and be prepared to suction. So those are upper airway issues that can lead to major respiratory compromise and depression and death. Now let's talk about some obstructive lower airway diseases. We talked about asthma and emphysema for some point, so let's talk a little bit more about it. When you have patients who have these chronic or reactive congenital airway diseases, they're going to be looking to get air out. They have to breathe air out. They can't get the CO2 out, so the container is filling, and with CO2, it's competing with the oxygen, and as a result, not enough oxygen is diffusing across, and therefore the affinity that hemoglobin has for the oxygen is starting to drop. So what you're going to see, compensatory process is kicking place. Pursed lip breathing, the increased IE ratio, 1:3, 1:4, 1 breath, 1 second inspiration, 4-second exhalation. Use of accessory muscles and jugular vein distension, you have increased pulmonary blood pressure, pulmonary hypertension. So looking at patients with asthma, very common disease that we deal with a lot. It's almost passe for us as experienced medics to treat asthma, but understand the new sciences that are out there. And so you got to be aggressive with your beta agonist, with your sympathomimetics. You use your albuterol, that's great. Keep giving the albuterol, talk about reducing the mucus secretions with the Atrovent, merge it together, that combination treatment, keep giving it. And what they're saying is cascading treatment is very, very important in our care. We don't want this patient to go into status asthmaticus. I mean, sometimes it's not something that we can even control. They're just not responding to our cascading treatment of albuterol. So at that point, we're going to make a decision on whether or not we're going to give epinephrine. And it's a very dangerous drug, and you understand the side effects. And this is for asthma. This is not COPD. This is asthma. So if you have a 75-year-old who's having trouble breathing secondary to COPD, and you're giving the treatments and it's not responding, that's not a patient who would get epinephrine. Cardiovascular system is already compromised. It's going to potentially cause VFib. We're talking about younger people with this reactive airway disease, asthma, who can handle that overstimulation of the sympathetic nervous system. It's really a last-ditch effort. It shouldn't be your first-line med. It's a second-line med. And then after that, you're going to start thinking about smooth muscle relaxers like mag sulfate, and you're going to start thinking if the mag sulfate's not working and the epi's not working, you're going to have to take over airway and intubate this patient. So different things can cause asthma. It is by nature congenital reactive airway disease. So it can be triggered by weather, it can be triggered by infection, it can be triggered by stress response, whole myriad of things that can actually cause this. And you can see the bronchospasm that happens in asthma. But also with the bronchospasm, we can have a buildup of mucus, and this increased mucus production leads to edema. That's why we're into the CombiVent, the combination of the sympathomimetic and the parasympatholytic, blocking vagal tone. In addition, patients who are not taking in fluid, they've been sick for a couple days, and that's what triggered their asthma, the mucus can get very thick. These secretions cannot be coughed up. So someone who hasn't had good fluid intake, who's had a dry cough for 3 days and they're feverish, and now they're triggering their asthma, these patients need to be rehydrated in addition to the albuterol and the Atrovent. So we want to think about correcting the bronchospasm with the sympathomimetic, with the beta agonist. We want to think about the bronchial edema initially with the blocking the vagal tone, but also corticosteroids. But once again, think about the whole patient and the history. If they've been sick, they're feverish, you really don't want to give them something that's an immunosuppressant. You want to think instead about hydration. And we're taking the patient to the hospital. Sometimes whether they like it or not. Sometimes they just call you, as you know, to get a couple treatments, feel better, and sign a refusal. They need to be followed up at the hospital. They might not know that, so their refusal to go is not an informed consent. So if they don't want to go, you have to inform them that this is a very serious situation and they could possibly die from this. And they need to, at that point, if they don't decide they still don't want to go, I would get medical control involved. Because you've given a medication. Anytime you give a medication to a patient who doesn't want to go to the hospital, you need to get that clearance through medical control. Now, COPD, another chronic disease that is brought on by different factors. It could be environmental, primarily things like smoking, exposure to hazardous materials like asbestos, and things, over the course of life will lead to this issue where the alveoli collapses and turns into one big ball instead of 20 little balls. All right, chronic bronchitis is sputum production most days of the month for 3 or more months and lasting 2 or more years. So to have that diagnosis, you have to have followed up by a physician. Patients who have emphysema, they have that barrel chest appearance, their lungs are chronically hyperinflated because those balls, those big balls of alveoli, instead of little balls, they trap air, they can't get the air out. So the trapped air creates this barrel chest appearance. With that, you're going to have increased mucus production and wheezing. In an exacerbation of someone's COPD, there'll be wheezing. What can cause this type of wheezing? Like I said, mucus production, but left-sided heart failure. The right side of the heart, when it fails and causes that pulmonary hypertension, can lead to left-sided heart failure as well. And you build up fluid in the lungs. It's a mess. So patients who have chronic obstructive pulmonary disease have respiratory disease as circulatory disease as well. So our treatment for them is not going to be as aggressive as an asthmatic. You have to look at your patient, see what their underlying history is, what's happened, the history of the present illness and the exacerbation. Why are you here? These people suffer with this disease every minute of every day. So for them to call you, there is an exacerbation, there is a problem that's out of their control. All right, so they're going to need hospitalization. The last thing you want to do with an asthmatic is intubate. The very, very, very last thing you want to do with a COPD patient is intubate them. COPD patients with right-sided heart failure, we want to look for peripheral edema, any JVD, look for that hepatojugular reflex. That's very common in COPD patients. The end expiratory crackles, improper use of diuretics can dry them out and cause increased thick secretions down the lower airways. Now, anything can trigger the COPD, so talking to the patient will help you understand why you're there, taking care of them. Unfortunately, there's no cure for this, and because of the circulatory involvement, this is going to have systemic properties, and end-stage COPD is it's not going to end well for this patient. You got to remember that you want to treat them, but this is something that has taken decades to manifest, and you're not going to be able to cure them in the 10 minutes that you're spending with them. But you've got to, if it was serious enough for them to call you, there needs to be hospitalization involved. They need either IV antibiotics, they may need to be on a vent. But you can't treat a COPD and then leave them at home because of all the risk of cardiovascular collapse. You want to instead talk about improving immediate distress and start giving them some albuterol treatments, maybe even just if you feel like they've taken too much albuterol and their blood pressure is high and their pulse rate is high, maybe if you just give them some saline that will maybe break up some of the secretions that's causing the inflammation, by changing that thick mucus into more soft, supple, and controllable mucus. That might be enough. You got to understand what their drive to breathe is based on. Some severe end-stage COPDers, the body has lost its ability to regulate breathing based on high levels of CO2. The pH is completely out of balance. The body can't regulate it anymore. And that part of the brain actually shuts down. And now this patient is on a fail-safe drive known as the hypoxic drive. The hypoxic drive is just based on low levels of oxygen. The trigger to breathe is based on that low level of oxygen. And breathing can be regulated that way. Hypothetically, if you give this patient large quantities of oxygen, you will cause the hypoxic drive to no longer feel it's necessary to take a breath. So you have to be aware of end-stage COPDers to be very cautious using oxygen, especially in long-distance transports, because the short time, the 10, 20-minute 911 treatment is not going to affect the hypoxic drive. But if you go into a couple of hours of oxygenation, you can start disrupting the hypoxic drive, and yes, your patient could actually stop breathing. So, you know, this is why you get yelled at by nurses when you come in with a patient on oxygen who's got end-stage COPD. Oh my God, they're hypoxic drive. You just explain to them, look, you can take it off. The 20 minutes, it helped them because I corrected their respiratory distress, but you can take it off. That's not going to affect the hypoxic drive. That takes hours. But if you're doing a critical care transport, maybe a fixed wing transport, and you got a patient who's COPD, you got to think about that hypoxic drive. It's something that it's rare, it doesn't affect everybody. Not all COPD patients have the hypoxic drive, but they're more of an end stage issue. We always give oxygen. There's no contraindication in the field for giving oxygen. Encourage them to breathe, give them a treatment, you know, and the cells still need oxygen to survive. If the patient becomes apneic, it's probably not being caused by the loss of the hypoxic drive, it's probably being caused by severe hypoxemia, so we're going to have to intubate this patient. Of course, find out about living wills, DNRs, most forms in New York, you know, the decision the patient has on whether they want to be intubated or not, or they just want to have supportive care. Now, if you ventilate a patient, you have this auto PEEP function. Patients try with pursed lips breathing to create this auto PEEP on their own, where it allows complete exhalation before the next inspiration. And what that does, in a way, is get rid of any excess CO2 and provide more container space for oxygen. So once again, asthmatics, aggressive with the sympathomimetics, the beta agonists, but look at cause and effect. Should I give the corticosteroid? Is the exacerbation based on a disease? Are they sick? Are they battling something? Then are they dehydrated? These are the things you look for. With COPDers, we're very cautious with them. This is the start of care. If they're exacerbating COPD where they can't maintain it at home, we're not going to cure them and let them stay home. They're going to the hospital because there's a whole different issue. Remember that hypoxic drive if you're doing transports, things like that. Now, infections, pulmonary infections, because this is an entryway, it's very susceptible to microorganisms taking control and causing an infection. So resistance to the airflow will increase when the airway diameter is near, right? Basili's law? All right, so the alveoli can be non-functional if it becomes filled with pus, like you find in pneumonia. So a greater risk of pneumonia with older people, they lose the ability to cough. The cough reflex is not as strong as it used to be. Chronic illnesses like COPD will create more mucus that cannot be coughed up. Smokers have this problem because smokers produce mucus. They don't have cilia, they produce more goblet cells to combat the smoky environment. And immunocompromised patients, they're not able to combat at the alveolar level any infections. The alveoli have a network of white blood cells that combat infection, an infectious agent that makes it down there, but they're immunocompromised, they don't have that in place. So patients will have several hours of days of weakness, they get a productive cough, feverish, chest pains, sometimes increased by coughing, inspiration. It can start abruptly, it can be gradual. Now during your examination, you know, these patients might look extremely sick, like pale, like awful. But when you give them a little oxygen, they perk right up. Okay, so, you know, these patients, in addition to being a little hypoxic because we're not being able to let oxygen shift across, they can't diffuse across because of the pus that's building up, they're also dehydrated. So really when you give them oxygen, you think about fluid, give them a little fluid challenge. That'll sometimes perk them up. If you find yourself with a patient with an upper airway pulmonary issue, aggressive treatment is required. Oxygen and rapid transport. Lower airway issues, you treat for the wheezing and the underlying chronic congenital problems like reactive airway disease. And oxygen is always good, IV therapy and rehydration and transport. Now, atelectasis is the collapse of alveoli. It can be brought on by different attacks, either by liquid like pus or blood, but also smoke damage, toxic environment damage. And what happens is when you have that collapse, you lose the functional capability of the respiratory center. So our management is having the patient, and they're in the hospital, of course we take them to the hospital. These patients are forceful coughers. They try to have them breathe in deeply, and they use what's pictured here. This is an incentive spirometer where they force air out. It increases our auto PEEP function, inflates the capillary on the alveoli. Lung cancer, one of the most common forms of cancer. Number one cause of lung cancer is smoking, but also exposure to hazardous air, like working in a factory and not taking respiratory precautions, is another leading cause of this. And the thing with cancer is lung cancer can spread metastatically and go to the entire body because it has an easy access through the capillaries in the alveoli. So the first sign is hemoptysis, coughing up blood, and depending on where the mass is located, you can end up having a collapse of the alveoli because you can look like you have a COPD, and it does metastasize quickly. And there's very little prehospital treatment for this pleural effusion or hemoptysis. Patients who have lung cancer, there's a lot of advanced directives in place, so you want to be very aware of them and have them with you during any transport, either 911 or interfacility. Toxic inhalations, this is chemicals that can damage. Irritants, choking agents, vesicants, things like blistering agents, like ammonia, chlorine, phosgene, different things can bring on respiratory inflammation, destruction. Patients who have inhaled toxic substances, they're going to have upper airway swelling, hoarse throat, probably burns around the upper airway that are visible. These are for high water soluble. Now, less water soluble, get deeper, more damage over time. What you find very common is this moderately water soluble, like mixing drain cleaner and chlorine. Ammonia and chlorine together makes an irritant chlorine gas. Chlorine and water can create hydrochloric acid. I mean, that's basically what a pool is. You're going swimming, nice summer day. What are you diving into? A vat of hydrochloric acid. But it's a very weak hydrochloric acid. But the chlorine and the water are mixing together, and it is acidic in nature. So what are we going to do for these patients? Well, we want to get them out of there, okay, after our safety is secured. We want to remove them, we want to decontaminate them. 100% oxygen, you may have to start doing positive pressure ventilations and intubation to control the airway. Pulmonary edema is that fluid buildup, and it can be caused by toxic inhalation, damage, irritation, but also by increased hydrostatic pressure caused by left-sided heart failure, backflowing blood, and the only way it can relieve that pressure is at the permeable vessels of the cardiovascular system, which are the capillaries. Closest capillary beds from the left atria are surrounding the alveoli. So by the time you hear these crackles, fluid has already leaked into the capillaries. The hydrostatic pressure is extremely high at this point. The alveolar walls are swollen, and we have seeping. That seepage has to be addressed. So you want to listen to the lower lobes in the back, and you hear crackles, And sometimes they have watery or that pink frothy sputum. That's how you know that it's plasma in nature. Now, pneumothorax is when air collects in that potential space, the pleural cavity, between the pleura and the rib cage. This should be potential space and have nothing in between it. Air that's loose in there, that frank air will cause changes inside the thorax, so it will get in the way of proper ventilation. So patients who have something like a spontaneous pneumothorax, they'll develop suddenly and after coughing a lot of times. And it will start to get worse as the pressures increase. Spontaneous pneumothorax patients need to go to the hospital. You don't necessarily, it won't turn into a tension pneumothorax where you'll see a shifting of the mediastinum and all these structural issues like subcutaneous emphysema and that tracheal shifting. But they do need to go to the hospital to have surgical intervention. Pleural effusion, that's an infection in the pleural sac. And once again, that's that potential space that's being violated and expanded, and that's going to get in the way of breathing. With a pleural effusion, a lot of times these patients have a lot of pain on inhalation. So putting them into a nice position of comfort, full Fowler's, 90-degree angle is the best, and oxygen. Pulmonary embolus, we mentioned before, this is a blockage of the pulmonary arteriole, preventing blood flow into the capillaries for gas exchange to take place. So we'll have ventilation but no perfusion. We'll have a VQ mismatch. It can be caused by a lot of different things, in addition to blood clot, fatty or amniotic embolus, and an air embolus from a faulty IV. And how do these patients present? Severe hyperventilation. Severe hyperventilation, anxiety, sometimes carpal spasms. Sounds a lot like hyperventilation. So be aware. Do a full assessment on all hyperventilation patients. Find out a history. What did they recently deliver a baby? Recently gave birth? Have they had a extended bed stay from a leg fracture? What's their medical history? They take Coumadin. Why? Because they have thrombocytopenia. They have a buildup of red blood cells. Are they a smoker? They take birth control pills. A lot of these things can bring this on. What they need to do is get to the hospital where the clot is removed and the patient is inserted a Greenfield filter, which this is patients that get extended stay bed rest. It's a filter that actually traps blood clots from returning back to the heart. Now, an extreme embolus that gets in the way of all perfusion is known as a saddle embolus. And these patients are severely, this is almost immediately fatal. You come to the scene and the patient's in cardiac arrest. This isn't a patient who has any complaint. You make no real conscious contact with them. They're dead. And when you're doing CPR on them, they just stay blue. That's called cape cyanosis. You know, there are age-related variations that we talk about. You know, that when you're young, structures are in place. They should be operating effectively. When we get older, they start to break down. Asthma is more reactive and it's a younger disease. COPD is a progressive disease that takes decades to manifest, so it's usually an older patient. Remember with children, the real issue is airway control. They have big heads, little bodies. Think about South Park. Look at Cartman. Big head, little body, stubby little legs. In addition to infants with these big heads, they're hypermetabolic. They're growing. So there is a higher oxygen demand required for them to continue living and growing. So they're going to be breathing faster, their tidal volumes are lower, okay, and they also have limited abilities to compensate. So looking at a child with respiratory distress, the number one cause of cardiac arrest in children is respiratory arrest. Remember that. It's very important. So when you're doing your entire scheme, patient assessment, Your focus as a paramedic is to look at the respiratory center. Control the airway. If the patient is talking to you, that's great. They have control of their tongue, they have control of their airway. Wonderful. Problem solved. If they are not in control of the airway, we've got to take control of it. But if they are in control of the airway, give them oxygen. Nothing can be bad from giving oxygen in the acute setting, because it's going to affect the way hemoglobin is attracted to it. It's going to aid in the diffusion into the blood, and it's going to provide a good way with good perfusion to get it to the cells. Right? Use all of your diagnostic tests to show that normal processes are working, that we have good torr pressure of oxygen. We see that with pulse oximetry, and we want to see our good torr pressure of CO2 with end titles. Torr variations for oxygen, 80 to 100 is the range. 80 to 100 torr millimeters of mercury. 35 to 45 is CO2. Maintaining that allows you to keep your patient in a state of homeostasis, normal metabolism. Anything that alters it, we have medications, and based on the problems, we can address them. So remember to review all of your different types of treatment modalities for different respiratory issues.